It's happening. Dr. Ali Rezaie is here, hot, coming in hot from Cedars-Sinai. And we have Dr. Allison Siebecker, SIBO Specialist, and my major collaborator on all things gut. And she always makes the conversations more useful, and she's one of my besties. So, of course, I wanted to have her here. Dr. Rezaie, you're an inspiration to so many patients that there is hope. And I know that you and Dr. Mark Pimentel are working tirelessly along with the entire team at MAST. So Dr. Rezaie, for those of you who are not quite sure, like I've heard of him, wait, what? He is the medical director of gastroenterology motility medicine at Cedars-Sinai. He's also the director of bioinformatics. That's a great word. And biotechnology at MAST, Medically Associated Science and Technology Program. Here is a chance for you all to directly connect with a world leader, a thought leader in motility, in SIBO, in IBS, in technology for mapping the microbiome of the small intestine. The patents, have you gotten the patents yet? Or are they pending still?
Oh, I mean, there are regarding, I mean, you can patent genes. Like that's
I meant for the Lotus and all that.
The Lotus. I mean, that's for aspiration catheters and all that. So yeah, so there are works on that, but that's a good point. I mean, nobody can patent genes and DNA of live animals out there. It's for everybody to study.
And we're so glad that you're doing it. Thank you.
Yeah.
Okay, here we go. I'm going to start diving in with questions right out of the gate because I want to maximize every minute. So Clarissa is going to put the link for the summit, the Gut Rescue Summit that I've been working on for a year. That is all master classes, guys. This is a conference level event that if you watch for the next 7 days is free. Today's the first day. Clarissa will put the info in there. You can see Dr. Rezaie's presentation along with over 40 other incredible experts. Dr. Rezaie, what is the mechanism of action when SIBO is caused by norovirus? Do you think that's an underlying cause, Doc?
So yes, so there are actually good studies in terms of epidemiologic studies. Based on when there's an epidemic, then people go and watch that group of patients that's very affected by that epidemic, and then they just follow them along. I mean, mostly that is done with a bacteria, and in a few exceptions, some parasites. But yes, people have followed people with viral gastroenteritis, whether norovirus or other the viruses. So the rate of post-infectious IBS and generally actually post-infectious symptoms are lower with viruses. The classic post-infection syndromes that we hear, for example, Guillain-Barré or post-infectious gastroparesis, which stomach doesn't work. Guillain-Barré is when your nerves don't work and you start to get paralyzed. That type of reactions generally are seen with bacteria more as opposed to viruses. Now, post-infectious IBS is similar. It's more common among infectious gastroenteritis with bacteria, namely Campylobacter or E. coli or Salmonella. But it can happen in the setting of viruses as well, but with lesser intensity and usually with much less prevalence. So what causes it? Simple, we don't know. So the multiple pathways have been looked into, whether from the mitochondrial pathways, from the microbiome pathways, or from the autoimmune pathways. If I have to bet, generally speaking, post-infectious phenomenon and post-infectious syndromes are occur based on three sort of pillars. Pillar number one is change in microbiome. Pillar number two is remnant of that bacteria in the gut still staying and becoming a colonizer, and that's not usually the case in all infections. And pillar number three is autoimmune reaction, immune reaction to that infection that can be lasting beyond that infection leaving your body. So these three kind of work together and lead to sort of like symptoms. And if I have to bet, post-viral infection leading to IBS, it probably follows the same pattern. Now, we haven't found that specific antibody or immune reaction pathway, but I'm pretty sure one day we'll find it. And it's not like people are not looking. If you look at more obvious post-infectious phenomenon, such as Guillain-Barré, that has been going on for more than half a century, the research on that field, people still haven't found those pathways. But there has been great breakthroughs in treatments of it in the last few years. But in terms of diagnosis, still remains a clinical diagnosis, which again tells you it's just not easy to figure that out.
All right, we have a lot of questions, so I'm going to zip along here. Any new treatment ideas for lowering antivinculin antibodies post-infectious IBS? Thank you for your work, Tristan says.
Well, I mean, easier said than done, because here's the problem with anti-vinculin antibodies, right? So these are your own cells. These are lymphocytes B cells that produce antibodies, right? So these are the same cells that produce antibodies that, let's say, you get the vaccine and they produce antibodies to protect you, right? These are the same cells that they produce antibodies when you're exposed to any infection. Now, there are different types of B cells, and many types. Figuring out which of those are producing antivinculin, which we're working hard on it, and also figuring out how many types of antivinculin out there among humans, right? So if you go develop a anti-vinculin sort of like treatment, and it turns out that is only present, that a specific anti-vinculin is only present in 5% of the people, well, that's not going to work. So you have to figure out a more covering sort of approach to it. So those are the steps that you need to figure out before developing a treatment, which we are working on. Another issue is that you don't want to go out and kill the B cells, right? Because the B cells are doing other good things as well. That's why we have immunity. That's why they are the memory cells that help us fight with the infections much easier when we have gotten it in the past. So that approach is not really feasible in the setting of antivinculin antibodies for me to go and just knock out all the anti-vinculin antibodies. On the other hand, going and clearing the antibodies also is not probably a long-term solution because those cells are there, they're going to produce it again, right? So that's the tricky part. So it's probably going to be a combination therapy or a very specific therapy. So it's at the animal stage right now. So getting it to humans, there's some work, but hopefully we can push things out.
Okay, for those of you familiar with antivinculin and some of these terms, be sure to watch Dr. Mark Pimentel's presentation in the summit and Dr. Rezaie's, because those two things will give you a ton of backstory. So Ramona is asking, 49-year-old female who has undergone 4 rounds of SIBO IMO treatment, herbals and pharma and elemental diet, but never given a pharma prokinetic, still experiencing severe bloating. What is likelihood she still has SIBO IMO, or is it likely that the bloating is due to fallout of the SIBO treatment and needing to do some major microbiome restoration work? Ramona, did you retest? I'm just curious.
All right. So yeah, so that's the first question. Have you retested yourself? Because if you have retested yourself and now you see that, oh, there is no SIBO or IMO and I'm still having symptoms. Remember, the bloating and abdominal distension can be caused with many and by many sort of factors, right? So yes, SIBO is a very common sort of cause of it, and IMO is a very common cause of it, as probably they're the most common cause of bloating and abdominal distension, but that they're not the only causes, right? So whether it can be a microbiome sort of related issue, right? So the small intestinal fungal overgrowth that we're more and more learning from. So that's one possibility. And outside of that, it can be this motility, a lack of movement of the small bowel, which is very intricate, that can lead to abnormal digestion, abnormal motility of the gut that can be perceived as bloating by us, or it can even show itself as abdominal distension, especially in the famous cases of chronic intestinal pseudo-obstruction, which is literally small bowel is semi-paralyzed, and these patients are constantly bloated and distended. Now that I'm saying that you have this, but I'm just saying that if you're getting multiple treatments and your breath is now normal, or it's normalizing, things are improving, but there is absolutely no improvement in your symptoms, you have to keep an eye open that this is not microbiome dependent. Not everything. I'm a microbiome researcher. I'm happy to be told that everything on this planet is caused by microbiome, but that's not the case, right? So you have to keep an open eye of what else is going on and rule those out.
Okay. So, $1 million question. What's new from research that can be translated into the clinic for treatment of IMO, intestinal methanogen overgrowth, and SIBO?
Well, I mean, our big conference, Digestive Disease Week, is coming in May. We're going to have a whole group of benchside translational research and also clinical research that are relevant to IMO and SIBO and also directly affecting them. So in terms of a ton, it will come out in terms of basic science, in terms of techniques to diagnose, and also in terms of correlation of breath testing and small bowel aspiration. That's going to come out. But more importantly, we just actually finished because we all have been talking about elemental diets, right? So elemental diets have been a mainstay of many diseases in GI that we treat patients with, especially when the symptoms are refractory, when the symptoms are not responding even in our regular treatments, especially in the setting of eosinophilic esophagitis, when there is eosinophils in the esophagus, in the setting of Crohn's disease, in the setting of ulcerative colitis, and in the setting of eosinophilic gastroenteritis, which is eosinophils are all throughout the gut, and these are inflammatory disorders that respond really well to elemental diet. So we just actually finished a clinical trial with a elemental diet, and probably you've seen Dr. Mark Pimentel's study that was done almost 20 years ago. And if you look at it, that was actually a retrospective study that was looking at the patients that was done. This was actually the first prospective, meaning that we did it actually on patients and followed them along, clinical trial with elemental diet in SIBO patients and IMO patients, and we had great results. And we're gonna review that, and that's not gonna be it, right? Because these patients now gave us breath, gave us urine, gave us stool, gave us blood, and we did this before and after. So by crunching these numbers, hopefully, and now we are already getting some great results to predict who responds, who doesn't respond, and if you respond, why do you respond, right? Because that's all matters, how to treat that. So I would say that's actually the biggest news this year for SIBO and IMO in terms of the prospective trial on elemental diet and how that works, and what positive and maybe some negative effects that they can have, and how can we mitigate it. So that's the big news that will come out at the DW.
All right. Well, that's exciting.
Right.
So the work for like a pill, an antibiotic, that's after that?
Well, I mean, the antibiotic, so you have to approach this in multiple pathways, right? So, antibiotic, which is less toxic to the other bacteria, but more effective against pathogenic bacteria that lead to bacterial overgrowth. That's obviously the goal and the easiest path to do so. So that's the work that we have been doing. The results, I mean, the initial clinical trial, for example, there were some very good results. And now, it has to go through its motions, pathways of like getting a medication through like FDA and getting things approved and answering the questions. That's not an easy path. Yeah, but it's moving forward. Yeah. Yeah.
Okay.
Yeah. So it's not after that, it's parallel.
It's parallel.
But
Okay.
yeah. All
Yeah.
right.
So I just need to adjust expectations. There's no way I'm getting to everyone's questions today, but I am trying to take a sampling and trying not to repeat. So I just want to let you all know, this is my jam. I'm here for you. Any hydrogen sulfide SIBO treatment updates?
Hydrogen sulfide, yeah, well, if you're talking about clinical data, and not necessarily, but in terms of translational and bedside data, yes, there are multiple pathways that are being targeted, and we're targeting to see if we can first suppress hydrogen sulfide production, or suppress hydrogen sulfide producing bacteria, or stop substrate from entering the hydrogen sulfide producing bacteria to sort of to see which one of these approaches are more effective and more feasible to do. It's hydrogen sulfide producing bacteria are a little bit evasive in terms of medications to reach them. So that's what makes it a little bit tricky, but that's also makes it exciting to take that challenge. But yeah, so the work is being done.
Okay. All right. This is exciting. Very, very exciting. Let us know if we can help in any way, doctor. We're here for you. Okay. I just wanted to ask you, Lena, I'm with you. You had a very important one. Here we go. Because there's a lot of people asking about fungal overgrowth. Does fungal overgrowth have to be cleared to treat SIBO and keep it from returning? And then how do you take on fungal overgrowth?
Uh, Interesting. I'll answer this from this way. So in the lab, when we're growing in the gut environment that we produce, and then we try different bacteria side by side, what we see is that the bacteria and fungi obviously compete, but it's kind of like a love and hate relationship. It's sometimes the growth of fungi when the bacteria is very high, especially E. coli, is actually gets suppressed. And that's actually not new. That has been shown before. On the other hand, when there is fungi, sometimes it does affect the growth of bacteria, especially the native bacteria. So is small intestinal fungal overgrowth a problem? Yes, it is a problem. And is it go hand in hand with SIBO? But that's the data that actually we showed last year. Yes, very commonly it can be seen with SIBO and SIFO at the same time. Now, figuring out how much of the symptoms that patients have is secondary to SIFO or versus secondary to SIBO, that's not easy to tease out. But if you ask me, the majority of the symptoms are coming from the bacteria SIBO. But yes, they do coincide with each other, but it can be also standalone, or it can be a sampling error, right? Because remember, whenever we're checking for the small intestinal fungal overgrowth, which at this point, the only way that we know of to diagnose it is through the small bowel aspirate, we always have a sampling error in the small bowel, right? So there's different segments of the small bowel. I can't reach the whole 20 feet of it. I'm taking different samples of different segments. So we probably are gonna miss some of the the coexistence of SIBO and SIFO. That's in cases that we see SIFO but no SIBO. In fact, actually, one of the data that we're going to present, I can just touch on it at DDW, is that we went in different segments of the small bowel. There is a technique called double balloon enteroscopy, which is a very long scope that can go through the whole small bowel. It takes about a few hours to do, and it's very invasive. But through that, we took samples of different parts of the small bowel. And the rate of SIBO, although they correlate in different segments of the small bowel, is not 100% concordant, right? And that just tells you the small bowel itself at that segment may not necessarily be the gold standard. It has some sampling error. And that's actually a very important point because so many times the small bowel laceration is considered as gold standard, but that's necessarily not true. It's kind of like a silver standard. It's not as bad as like a tin standard, but hey, it is definitely not gold standard because it has sampling error, because we sample like 10 centimeter of a 600 centimeter sort of like organ. Of course, there's a sampling error. It's naive to think that it's not. But that's one of the issues that we have, because there is no perfect test for small intestinal bacterial growth or small intestinal fungal overgrowth, because aspiration is not perfect, breath testing is not perfect. And in fact, if anything, these two are complementary. So keep in mind is that if you go out there and you're determining the characteristics, the function and accuracy of breath test against, for example, small bowel aspiration, that's not necessarily a sort of fair comparison, because that's not really gold standard, because it's already missing cases and it's already overdiagnosing cases with small bowel aspiration because you get contamination with the oral mucosa. So that's one thing to keep in mind.
Okay, what treatment do you usually use to treat yeast overgrowth?
So there is no clinical trials that have been done, and there are no even proper study, because the tough thing is that, okay, the best way to see if it's truly is gone, you have to go and re-aspirate as after the initial aspiration. So that includes 2 endoscopies, right? So it's very tough to do that clinical trial until you figure out some sort of non-invasive testing for it. So I said all that to tell you, yes, everything that I do is anecdotal in a sense. I mean, similar to what I have to give a credit to Dr. Satish Rao, which is much senior to me. He essentially put that protocol together. I do use 14 to 21 days of nystatin. That's one option. And if a patient doesn't tolerate that, I use fluconazole. So that's the approach. Again, understanding that that's an off-label therapy for small intestinal fungal overgrowth, because there is no on-label therapy for small intestinal fungal overgrowth. So those are the treatments that I use. And as you mentioned, the pro-motility drugs are also important, the same way that it's important for SIBO as well. Because, at the end of the day, if the small bowel, if the colon, if the bowels in general are not moving well, I mean, that's just an environment for different types of bacteria and fungi to overgrow, right? So if you give them a pro-motility drug, potentially decrease the chance of recurrence of those symptoms.
So for my birthday last year, Dr. Allison Siebecker bought me this t-shirt, "Are you on a prokinetic?" And that's what Dr. Rezaie is talking about. So for those of you who are not familiar with what a prokinetic is, it's not a laxative. Dr. Rezaie, do you want to define that for everybody? Because I know we have people in all different stages of learning right now with us.
Right. So pro-motility, essentially pro motility or prokinetic motility of the bowel. Our bowels constantly move, right? I think of your heart. So your heart is constantly beating. The same way, there is smooth muscles in our bowels that have very rhythmic and balanced contractions. And these contractions are supposed to be regulated and also propagating. They're supposed to push things forward. They're supposed to propel things forward. Not just food and digested food and secretions, and also the bacteria and whatever is inside the lumen of the gut, right? They push things forward and constant toileting, right? Think of it as a river that needs to constantly flow. Or to think of it as your heart, that it constantly needs to move things to get filled and then push things out. The same thing with the gut. It sort of relaxes to get filled and then push things out. Now, there are multiple things that affect the motility of the guts. It can slow it down. It can make it dysregulated or discoordinated, meaning that the contractions are not really propagating, they're just spastic. In that setting, then obviously a different type of bacteria other than our native bacteria start to overgrow and grow because that's not really a good environment for our body anymore, right? So the same thing with the heart, right? So if the heart slows, for example, in your heart, then all of a sudden the blood inside the heart clots, right? So, and that's where the disaster happens, right? So same thing in the gut. The flow has to be constant. Now, one of the main reasons that we get SIBO because we're encountered by different stressors that affect the motility of the gut. And now this can be medications such as narcotics. This can be the surgeries that can affect the motility of the gut, infectious gastroenteritis that we talked about, autoimmune disorders, diabetes, all that stuff can affect the motility. And so many times we just don't know why the bowels are not moving that well. So prokinetics are medications that essentially help the bowels move. And these are mediated by specific receptors. And these receptors can be motility receptors, can be serotonin receptors. And these receptors, when they're activated, they make the gut move. So that's what Shivan is talking about when she's saying prokinetic. So now if you give somebody prokinetic, you have to strike a balance of giving that person the motility without overdoing things, right? So obviously all prokinetics, if you go overboard, people get diarrhea because now things are moving too fast, right? So you have to strike a balance to have that balance that bacteria gets toileted, the intraluminal content of the bowels gets toileted without causing trouble, right? So that's the beauty of prokinetic drugs, because just giving the antibiotics, for example, over and over again, yes, sometimes that's what we got to do, right? So that's the refractory sort of cases of SIBO, and sometimes we end up like giving continuous antibiotics. That's not something that we thrive for, or we like hope for to do, but that's promoted drug at least decrease the chance of recurrence and those strategies.
So I have a lot of questions like with these complicated long-term cases, and several of you are not telling me if you've been on a prokinetic, because that's kind of the answer. Annika, anonymous attendee, you're saying I've been doing everything and it just isn't resolving. You have to explore those prokinetics. They're prescription, they're non-prescription. You can find out more about those at SIBO SOS and SIBOinfo.com. Dr. Siebecker and my site. Here's the book, Healing SIBO, that I wrote. She wrote the foreword, read every word. So, I'm not getting rich off this book. This is not like, oh, let's have an infomercial for the book. I'm just saying it's going to fill in a lot of gaps. And also watch the summit and Dr. Pimentel's and Dr. Rezaie's talks in particular. There are 40 experts there. Okay, I'm going to keep going here. What about low ferritin, Dr. Rezaie? Can chronic low ferritin levels below 15 be solely or primarily caused by issues in the gut?
Yeah, absolutely. So low ferritin, for those who don't know, ferritin is a marker of your iron stores, and it correlates really well with the iron stores inside our bone marrow. Iron is one of the main building blocks that we have to build red blood cells. And red blood cells, we need them to sort of like transfer oxygen all over our body. So iron is very important, and ferritin is a marker of iron stores. Now, there are many things that can deplete iron stores in our body. It can be we're not having enough iron in our diet. That's not that common in the North American diet. It can be because that we're losing blood somewhere. We're losing blood somewhere to a point that our bone marrow is not catching up and we're losing it. And that can be from any source. It can be from a GI source. It can be from a urinary source. It can be from a gynecological source, or it can be inside our vessels. The blood starts to break down, something called hemolysis, which can be autoimmune, or it can be because of an external sort of factor, such as a heart valve that is breaking down the vessel. So all that can lead to breaking the blood and increase consumption of the blood cells, red blood cells, or losing them. So another sort of issue is lack of absorption of the iron that literally has hundreds of reasons for it to happen. One important factor is the health of the small bowel integrity and mucosal absorption capacity of the small bowel. This can be affected by many things, including inflammation, classically in the setting of celiac disease, right? So it's inflammation in the small bowel. Now things can't get absorbed, right? So it's very common in patients with celiac disease to have iron deficiency, right? It's setting of Crohn's disease in the setting of other inflammatory disorders that can happen. Now, all these diseases are associated with microbiome changes as well, right? So they can lead to abnormalities and leading to low ferritin. So that's one thing that you need to figure out with your provider. What is the source of low ferritin? I mean, common things are common. For example, in women of a fertile age, for example, heavy menstruation is the most common cause of low ferritin. It's generally got nothing to do with the gut not absorbing or losing. But if you fix that problem and you're still having iron deficiency, that's what you need to look at.
Okay. So someone's currently waiting for a result of intestinal worms, and we're not talking about like TikTok and that everyone in the whole world has parasites. I don't know if you've been, I'm sure you've seen and heard about that, like everyone's doing a parasite cleanse. But this person felt like they never assumed they could get an intestinal worm or parasite in northern climates of the US. Can worms mimic classic gut dysfunctions like SIBO and others? And how the heck could I have gotten worms?
Uh, yeah, so northern climates, parasites are everywhere. I mean, wherever there are mammals and wherever there are animals, there are parasites. So that's not surprising to get parasites. Having said that, there are very accurate tests to diagnose a parasite. So make sure that you use and there are a lot of inaccurate tests to diagnose parasites. So make sure that you're using the right test to diagnose yourself. For example, in northern territories in Yukon, Alaska, and northern Canada, and in cold areas, for example, there is a worm that is called Difflubutirium latum, which is actually the largest tenio worm in the world. So this usually is in the fish, and then that can end up in mammals like elk when they're exposed to that water that are in there, and even bears that eat those salmon, and then they can get it. Right. So you can YouTube it when bears get it, but we can be an incidental vector for those worms. And one of the common presentations of that worm is B12 deficiency and also iron deficiency. Now, generally, they present themselves in a very sort of relatively subacute, if not acute way. So the symptoms are very dramatic, but they can present themselves in a subtle way. So yes, you can get it. It is what it is. That's make sure that if you go camping, no drinking water. I mean, if you swim in a lake, I mean, it is what it is. So if you're exposed to these tiny guys all the time, and we can get it. But if you're suspecting that, yeah, there are very good tests for it to be done that you can check for it.
Okay. What about Mirox? Is it bad to use that every day? Can it damage the microbiome?
Well, I mean, does it change the microbiome? It does. Does it damage the microbiome? Not necessarily, because the good thing about Miralax is that it's not absorbable by bacteria or fungi or by us. So it just washes through. It's a cleanse. It washes things through. So we don't have any data to suggest any abnormalities that can persistently stay. Yes, there are studies that show that, well, yes, if you when you do a cleanse, whether with Miralax or something else, of course your microbiome changes. You're just flushing the whole thing out, right? Whether that and leads to a bad sort of replacement of gut microbiome, there is no data to support that at this point. And another good heartwarming thing about Miralax is that this is something that we use for colonoscopy, right? So when we use we use it for daily use, we use about 17 grams of one scoop of it, right? But then when we use it for colonoscopy, before we use 4 liters of it, right? So, and these are studies that have undergone very vigorous analysis from multiple companies, probably tens of thousands of people on their clinical trials have undergone colonic preps, and they have been checked for abnormalities, and they have been shown to be very safe. What I'm saying is that this is something that you take it in nuclear doses, and that doesn't necessarily damage the gut. So small doses are should be safe. Now, obviously, everything is better to be natural, but again, that's Miralax is not something that worry us necessarily in terms of long-term use.
Any other tips for colonoscopy prep? Where people are like, it's quite overloading for a lot of people who have like small gut motility, slow gut motility.
Well, yeah, so for people who have a slow gut motility, what I usually suggest is that 1 day clear fluid, I usually extend it to 2 day clear fluid. Make sure that you hydrate yourself. Make sure that sometimes I increase the prep to 2 days to get things going, so the prep is more sort of effective and cleans the gut a little bit better. I don't necessarily do a stronger and heavier cleanse the day before. I extend the cleanse to 2 days to get things sort of going without dehydrating a patient. Make sure that the patient gets the hydration.
Okay. Could SIBO IMO contribute to diagnosis of L microscopic colitis?
So microscopic colitis is an interesting phenomenon that's where it's the lining of the colon. Now you have inflammation in it. So it comes into 2 forms: lymphocytic colitis and collagenous colitis. So the more common sort of type of it, which is lymphocytic colitis, is what we see the most. So lymphocytic colitis, multiple factors have been thought to be causing it. Definitely microbiome is one of it. And in fact, actually hydrogen sulfide producing bacteria have been considered as one of the potential causes of microscopic colitis. And this is to a point that there are two randomized controlled trials that I'm aware of that are ongoing. I think one is in Mexico, one is in Denmark, that they're using 4 weeks of rifaximin, for example, to treat microscopic colitis to see if it's effective or not. Yes, definitely. It's a multifactorial disease. We don't exactly know what it causes it. Sometimes it's associated with medication. Sometimes it's associated with other autoimmune disorders, very commonly in patients with celiac disease, very commonly in patients with Hashimoto's. It has been shown to develop. But sometimes there is nothing else. And microbiome definitely has been implicated in it.
Okay. Let's see. Let's see. Nope, that's already been done. I know there's a lot. I'm not going to get to everything, but I love you guys. Please watch the summit. You're going to get a lot of information there. Go ahead and put that link there. It's free for this week. All right. Visceral hypersensitivity. Gail has pain immediately during eating. I have IMO, MCAS, and Ehlers-Danlos. My GI doc wants me to take, is it Neurontin for the nerve pain in my gut, but I feel cautious about that approach to managing the pain. What are your thoughts? I'm sorry, Gail. I'm sorry all of you all are going through any of this.
So visceral hypersensitivity, it's essentially a general term that we use when the nerves of the gut are hypersensitized to the stimuli, right? So that is shown objectively that exists in patients with GI disorders. For example, in IBS patients, if you inflate a rectal balloon, they will feel it much faster than a healthy control. That just shows that that area is hypersensitized, i.e. visceral hypersensitivity. Now, visceral hypersensitivity is not a primary phenomenon. It can happen in the setting of multiple things. There are multiple studies are ongoing on that. We have shown that it's associated with SIBO. It's also, interesting enough, not necessarily with IMO, but it's mostly with SIBO associated. Other groups have shown that it's associated with histamine hypersensitization. Interesting that patient said that they have MCAS. So hypersensitization to histamine, there was actually a Nature paper 2 years ago that showed that if you expose mice to this infectious gastroenteritis, their gut microbiome it changes, but what happens is that the nerves of the gut are now sensitized to histamine, and the same amount of histamine sends bigger and larger sort of signals to the brain that they're in pain, right? So all these factors that are ongoing, this is to a point that now there are randomized controlled trials with antihistamines that are showing that visceral hypersensitivity decreases and improves in the setting of IBS patients. So what I'm trying to say here is that there are multiple factors that can lead to that. You can, that's why we try, for example, treatment of SIBO, visceral hypersensitivity gets better. We try to target histamine pathways to see if a patient feels better. We try to help with the movement of the gut so the bowels are not full, so they don't feel it as much with motility drug to see if patient feels better. Sometimes they don't work. Sometimes actually they may make things worse. Why? Because each patient's visceral hypersensitivity is not necessarily follows the other patient's sort of pathway of pathogenesis. So now, if none of these work, one of the ways, similar to the diabetic neuropathy, is to tell the peripheral nerves to suppress sending signals without having any central effect. And this is the approach that we take with giving Neurontin. So Neurontin is exactly that. It was developed for diabetic patients because they get a gloves and stocking type of pins and needles in their hands. And that's because glucose over long term affects the function of peripheral nerves. And when that is affected, yes, you can try to fix the diabetes as much as you can, but sometimes that nerve damage by glucose is not going to go away. So the only way is to tell those nerves not to send signals, and Neurontin, that's what it does through the GABA pathways. So that's one a reasonable way to try because Neurontin is not addictive. It doesn't have any adverse events on the motility of the gut. So it's an approach that we take when the basic sort of treatments don't work.
Okay. All right. What other journals do you like people to read who are here? All of us who are like super into this, aside from PubMed, do you have any other journals that you suggest? Where have you been published that you thought was great?
Well, I mean, we essentially all the peer-reviewed data that we publish does show up on PubMed, which is the National Library of Medicine. So it does show that. So that's a good source to use in terms of journals and papers. Yes, the challenge with that is that not every paper has open access, not so which is a problem. But if you can always search internet if somebody has uploaded sort of like that paper. If not, you can always contact the senior author, so maybe to see if you can get that full paper from that person. I mean, obviously, all senior authors get a lot of those emails, so I mean, they may right go to trash bin, so admittedly, but I mean that's one approach that you could take. Yes.
Okay.
Right.
Sometimes, you can get surprised. The other place to reach out is on LinkedIn, but do your searches, the Lancet, there are all kinds of journals, you guys. Okay. Yes. Didn't you already answer this? Could SIBO, IMO contribute to a diagnosis of L microscopic colitis?
Yes.
Yes, it could. Okay. You're not pestering. there you go. Okay. Yes. All righty. Have you ever seen a connection between SIBO and D-lactic acidosis?
Yeah, so that's so lactic acid is an acid that our cells produce when they're stressed. We produce that when the oxygenated breathing and energy production pathways are not there. Then you resort to the lactic acid pathways that without the need of oxygen, they can produce energy. The problem with that, it produces a lot of waste. And one of the waste that it produces is lactic acid. We, as humans, and also all mammals, produce L-lactic acid. So I don't know, going back to chemistry, remember there is D and L. These are isomers, right, of the same molecules. So we can produce L-lactate, but bacteria, interesting enough, are capable of producing D-lactate. So D-lactate is now toxic for us because our cells are not capable of breaking it down easily, and it can cause a grogginess, and if it's at high doses it can even sort of affect your level of consciousness. So this has been reported many years ago, going back like 50, 60 years ago, and cases of D-lactic acidosis of bacterial production. Having said that, we do look for it, not uncommonly, but we do look for it. for the D-lactate level in the blood. Also, you can check it in the urine. But I have to say, it's very rare. I'm talking about one case every 2 years that I pick one. It's not a common phenomenon that I find. Dr. Satish Rao again did publish a paper on this a while back using the urine test, which appeared to be more stable. One issue with the lactate in the blood is that it's it breaks down pretty quickly. So handling it is hard. So you have to take the blood, putting it on ice, run to the lab and run it. So it's not easy to run. So that has been at least my experience with D-lactate. So yes, it's out there, it's possible, but it's not common.
Okay. Could a mild case of C. diff resolve on its own?
Yes, can C. diff go on its own? Yeah, it can go on its own, because remember, C. diff has been around forever. C. diff is not a new bacteria, and antibiotics are only barely 100 years old. Before that, you just lived with it, whether you die or you live. So yes, it is possible for C. diff to go away on its own when the bowels slowly recover. Now, having said that, do we have any data on it right now? No, because it's unethical to follow somebody with a C. diff and not to treat the patient at this point. But is it possible? Yes, it is possible.
So you didn't say that SIBO tests are unreliable. SIBO tests, breath tests are reliable. So I just want to make sure that that's very clear to everybody. You always going to have a percentage of errors with almost any test, but
yeah.
Dr.
So
Dr.
I just
Rezaie,
said that, yeah. So no, the SIBO tests are not perfect. That's what I'm saying.
Right.
It's like not perfect doesn't mean unreliable, because there is no perfect test in medicine, period. And any test needs to be interpreted in the setting of pretest probability, i.e., okay, does this patient profile fit the diagnosis of SIBO? If you come to me say that, hey, I have toe pain, as opposed to come to me say that, well, I have abdominal distension that gets worse with eating and I have change in bowel habits, the pretest probability of those two patients having SIBO are not the same, right? So it does help. And also in the setting, right? So make sure that the test is properly done. And if the test is interpreted in the right clinical setting and is properly done, yes, it's a reliable test.
Okay, is there a relationship between SIBO and colon cancer?
So multiple studies are coming out in terms of correlation with SIBO and not SIBO, essentially microbiome and colon cancer. One study that actually we never published it, and because we are waiting for more data, we linked our 15,000 breath test at Cedars-Sinai with California Cancer Registry. So the good news is that we did not see any uptick of any cancer in the setting of small intestinal bacterial overgrowth, which is very promising. And this include everything. And, California Cancer Registry is very accurate. So we did not see that. We're hoping to, now that we have reached about 30,000 breath tests, to redo that link and do another analysis to see if there is any uptick. And you never know. Sometimes there is a protective effect. We will see if it's there. But based on the best data that we have, that we did almost like 4 years ago, there is no association of SIBO and any type of cancer that we know. Now, there are multiple studies that are linking specific bacteria to promoters or helpers of not getting cancer, but that's just literally sitting in the hypothesis box. We'll see how that goes.
Okay. When it comes to Allison, did you have something you wanted to say, my friend?
Nope.
We are wrapping up. Okay. Have you seen an increase in SIBO with people taking Ozempic? Slow stomach emptying, so I didn't know if it slowed the whole.
Yeah, so yes, the answer is yes. that we are seeing more with anecdotally. I am seeing it for sure, and it's not surprising. Ozempic slows down the colon, slows down the small bowel, slow down the stomach, and that's one of the reasons it works. And definitely it can potentially promote sort of bacterial overgrowth and change in the microbiome for sure. And now, this doesn't mean that if you have obesity, if you have diabetes, if you have cardiovascular risk in the setting of diabetes, you should stop your Ozempic, because at the end of the day, complications of diabetes that is uncontrolled, obesity that is not uncontrolled, can be fatal. So that's one thing that you need to address it. And Ozempic, there is no question that it's that is doing a good job in controlling our obesity epidemic, which was literally out of control.
Right.
I actually do have a question I want to interject here, because what I think a lot of us are wondering is, is it a good idea? Is it okay to put these people on prokinetics? Will we be counteracting part of the mechanism of action if we put them on prokinetics?
That's a very good point. It works on obesity, and also on the blood sugars on multiple pathways. One of them is obviously not moving fast. Yes, so you are counteracting that effect, but it also it has central effects, and also it has hormonal effects. You're not going to affect those. Can you potentially sort of decrease the efficacy in decreasing its anti-obesity effects? Potentially, yes. But if patient is not tolerating Ozempic, but pro-motility drug helps them tolerate the Ozempic, that's a very reasonable approach.
Guys, we have over 100 questions. There's, as I've said 3 times now, I cannot get to everybody's, but I am really trying. Adhesions, Dr. Rezaie. There have been some questions about adhesions, non-surgical techniques, like maybe the Wern method, Larry Wern, our friend. You could try neural therapy, Burrell Institute, Upledger Institute for visceral manipulation. How do you, when you see adhesions or feel like they've had abdominal surgery, they might have that as an underlying cause, how do you approach that?
Yeah, so that's a tough situation, right? And that's not a new problem, right? So adhesions is something that surgeons have been dealing with since surgery began, and it has been ongoing. And also more and more we're picking up adhesions in intra-abdominal adhesions in virgin abdomen, the people who haven't had surgeries. The most common cause of intra-abdominal adhesions without surgery is endometriosis, right? So when you have endometriosis and those endometrial seeds are outside of the uterus, they're very highly adhesionogenic, meaning that they cause adhesions. And that's one of the problems that occur in that setting. And you, so make sure that you tell your gastroenterologist that you have history of endometriosis if you do have history of endometriosis, because that kind of like change things, because if you have a severe endometriosis, i.e. an endometriosis that is outside of the uterus and is affecting other organs, then you have to fix the endometriosis first, because no matter how much you work on that, the abdominal pain associated with that and the dysmotility associated with that is not going to go away. So those are important points. Now, for adhesions, what do you do? For mild adhesions, yes, we have tried mild pro-motility drugs. We have tried peppermint and all that. Easier said than done, because sometimes when you give pro-motility drugs with people with adhesions, they get actually paradoxically more pain. And that's because essentially the bowel is tethered. Now you're giving him pro-motility drugs. Now it fights more instead of becoming more smooth. And that's kind of unfortunate that sometimes that happens. So I go with the smallest dose of pro-motility to see if I can help those patients. If obviously there is concomitant bacterial overgrowth, which is quite common in the setting of adhesions, I keep that at bay with treatments, with antibiotics or elemental diet if you want to use, or even sometimes in my patients, I replace one meal of the day with elemental diet to keep things going. So that's the one approach that I use. And then other things that you mentioned, deep visceral massage, definitely in mild cases is helpful, right? But in severe cases that are like thick bands of adhesions, well, deep visceral massage is probably not will be able to be super helpful in that setting, but it definitely helps in the setting of mild and moderate cases that will help patients.
Yeah. I honor your time. It is now, love ya. Let's put some love into the chat for Dr. Rezaie, everybody. Stick around. Allison and I have a few announcements and a couple of questions that we can handle. Thank you so much, Doctor.
Thank you so much, Ali. So good seeing you.
Pop
Good
that
seeing you. Anytime.
Thank
All
you.
right.
We'll see you
Thank
soon.
you, guys. See you.
Thanks.
Bye.
Have a great CDW and all that. Talk to you later. Thank you, dear.
Bye.
Bye. Bye-bye. What a treat. What an honor. He is such a get to have him speak with us. And I know there's some of you who are disappointed. I'm so sorry I could not get to everybody's questions, but wow, Allison, Dr. Siebecker, he really covered a lot of territory there.
Well, I don't know how you all feel, but I always say about Dr. Rezaie, I could listen to him talk forever, for hours and hours and hours. It's just
exactly
fascinating.
So interesting. I wanted to address a couple of things that Dr. Siebecker and I talk about all the time in the small group coaching for the people who are in our community, which you all are now. And by the way, if anyone wants to really dive deep and go granular into the SIBO recovery, we have the SIBO recovery roadmap course, and also you could add private small group coaching to that. So pop that in there if you would, Clarissa. If you are a pro and you want to learn more and enhance your clinical practice, Dr. Siebecker also has a beautiful pro course called SIBO Pro Course. And you can—
And I've got 2 mini courses now if you want to do it.
Yes, right. So
get in and out fast.
Yeah, exactly. Thank you. So Clarissa, I'll let you pop some of that stuff in there. Also, thank you for being here. We do have a 15 to 20% off coupon for everybody here for Dr. Siebecker's full script dispensary with over 20,000 personal care products, but most importantly, supplements like pure encapsulation, megaspore, integrative therapeutics, the elemental diet, on and on and on. So Clarissa will put that in there too. Thank you. For those of you who wanted to know about parasite tests, typically the Quest and the LabCorp tests are not sensitive enough. When those are positive, typically, you have it. Okay, you have a parasite. But if they're negative, it doesn't necessarily mean that you don't have a parasite. So some of the parasite tests that I know Dr. Siebecker recommends and that in the community I certainly talk about a lot are Para-Wellness. And that is, you just find it online. And then also we have, I just realized this, we have, of course, the Rupa test platform where there is the GI map with zonulin or not, which is the with leaky gut or not, that you can order on your own. And Clarissa, I know you're so good, Clarissa. Thank you so much. There's the link for that. And there's a variety of other tests there.
Also, I think there's the parasitology center is another one, right?
Yeah, exactly.
That a lot of our colleagues really recommend.
Yep, I wanted to mention that. And then, oh, he's at Cedars-Sinai, so you could Google him at the, thanks, Dr. Batista. Yeah, you can Google him. And you know where they're, Dr. Pimentel and Dr. Rezaie is on Twitter or X. Do they respond? I have no idea. They are obviously so busy. That's why, I literally booked the time with Dr. Rezaie like 6 months ago. I also booked with Dr. Pimentel, which Clarissa, if you could put that time and date there also in the chat, we'd really appreciate it. Yeah, you know what? We did our best. So thank you so much for being here. One thing I also heard him talk about on the presentation was if you drink a lot of water and you don't go and have a bowel movement, it might be because you have not added fiber. So that's something for you to think about. If you're like, man, I drink so much water and I'm still constipated. He was talking about how you really have to have fiber with the water so that it can do its job, versus your kidneys and your bladder and all that will take all that water and get it out. So you'll just urinate it out. So I thought that was a really interesting distinction, because I think a lot of people think, I drink a lot of water, why am I constipated? There's so many reasons why you could be constipated, of course, but that was a distinction that I thought was really, really fascinating. So I appreciate you all being here. And I wanted to also remind you that the summit is going on for 7 days. Dr. Siebecker is on there all over the place, Dr. Rezaie, Dr. Pimentel. It's all new. I think maybe there's Dr. Rao did a presentation for me and Dr. Siebecker about the Vibrant capsule. And that was last year, and not as many people saw it as we thought should. So I did put that one in there again. And also he couldn't do a brand new talk. I was like, well, I'm not doing a summit without Dr. Rao. And so that's who Dr. Rezaie was referencing several times about a variety of things. So he is in there, and I think that's a repeat. There are over 40 talks. Believe me, you'll get plenty of brand new, fresh information. And they're all primarily masterclasses. So they're 30-minute PowerPoint presentations that are definitely conference quality, but designed for both patients and practitioners to be able to learn from. So Allison, just and everybody, I want to just take you there real quick. This is, do you see it? Do you see the page?
I see a part of your screen, not your whole screen.
Oh, thank you, doll. There it is. Woo! You see
Yep,
it now?
we got it.
Okay, thank you. So there's a little video, but they're the superstars. Dr. Pimentel is going to be doing a Q&A for us as well coming up. Dr. Rezaie's incredible talk. All these presentations are phenomenal. The #1 underlying cause of IBS is SIBO. And then here's some of the speakers. William Davis, Supergut. Who's read Supergut? Who's eating yogurt in a different way now? There's Dr. Rao. There's Ann Hill. Phenomenal. I asked her to do 2 presentations on fatty liver, and I'll show you something else. Laura Frontero did a beautiful presentation about your brain and your gut. It was really, really, these are all really good. Sinclair Canale with lymph and liver stagnation. We have Sarah Ellis, who's talking about microbiome restoration after you take antibiotics. Tom O'Brien, no one loved Tom, right? All about gluten, but what's new. So it's easy to go, oh yeah, you're supposed to be gluten-free. Oh, I'm gonna have a cracker. Watch what he has to say. And the statistics about, oh my gosh, they'll blow your mind. Our dear friend Karen Krishnan is talking about metabolic issues. Christine Schaffner about mast cell activation, histamines. Julie Matthews about diets. And then Margaret Christensen. If you feel like COVID has played a role in your health, you need to watch that. Nicole Daneza, we love her on YouTube. Vagus Nerve to Better Health. Reed Davis, he trains so many functional practitioners and has such a fascinating approach. So there's Roland Pankowicz. He's part of one of the big enzyme companies, How Your Microbiome Influences Aging. Think about that's kind of disturbing. There's Dr. Stephen Sandberg Lewis, a dear, dear friend to all of us here, getting to the heart of heartburn. Somebody was asking about GERD. He is truly, truly a world-renowned expert in this. Roy Steinbach and Debbie Steinbach, they are experts in the elemental diet. So definitely watch theirs. Jabin Moore about leaky gut. He's also a parasite expert. Here's Michelle Sands talking about hormones. Kevin Ellis about bone health. And I was like, Kevin, how are you going to pull bone health into gut health? Oh, he did. He did. He changed one of my major habits after that. William Pollack, he is fascinating about PEMF. If you don't know what that is, be sure to watch it. There's Alicia Galvin. She's with Microbiome Labs, and she's talking about another metabolic talk. There's a lot of metabolic issues that are happening, right? And that impacts your heart. Remember, it's not just about blood sugar and insulin and prediabetes and diabetes and weight. This is a heart disease issue. Big time connecting of the dots there. Claire Short, anybody curious about Food Marble? That at-home breath testing device. She is part of the family-run company that created Food Marble, and she's a PhD and studied the microbiome to get her PhD. Very, very important talk. Isaac Ilyas, he's a cancer expert, glyphosate expert. Really, for those of you who are interested in that bigger picture of our environment, please, Jill Krista. I feel like I'm just having like a reunion with my friends here. Mold expert, and a phenomenal teacher and really advocate for all of us about how we can resolve mold issues in our bodies and our lives and homes. Dr. Jason Horlak. I think he's an international treasure, right, Dr. Siebecker?
Oh yeah, some of the best talks ever.
Happy gut, happy mind, the gut-brain connection and mood disorders. He's
a researcher, you know, and clinician, which is like Dr. Rezaie, the best combination, best of both worlds.
And all about microbiome and strains, different strains. Here's Carolyn Ladowski. She taught me more about genetics and DNA than anybody I've ever talked to. And I've talked to a lot of people about that. She's talking about gut check, unveiling your inner ecosystem. There's a new stool test that she actually did herself for the talk and then talks about it. And then Akil Palnasami, he reached out to me and was like, hey, I wrote this book. I read it. I thought it was so good. I invited him to be in the summit. He's new protocol and an MD very interested in natural healing. Yes, there are a lot. Steve Wright, enzymes. I'm like, Stephen, I need a masterclass on enzymes. People are confused. What do I make sure is in there for carbohydrates? What do I make sure is in there for fats and proteins? I'm like, break it down for me. And that's what he did. Here's Larry Worm. So you heard me say his name. Adhesions. If anybody has had abdominal surgery, a traumatic brain disorder, a softball to the gut, and your gut was never the same.
Yeah, and they have a hands-on technique that they have published studies that actually works to dissolve adhesions with actual published studies in PubMed. So really important.
Geraldo Magarinos, he is a dentist who is also connecting your oral health and microbiome to the gut microbiome. Phenomenal. Mona Morstein, another dear friend of ours, supplement analysis and 3 gut supplements. So I asked her to do a masterclass on supplements. And she was like, I'm ready. She went in there. You know, Mona, man, she gets a topic. She is like a dog with a bone. She did such a phenomenal job. You all will get answers to what you are looking for, like, hey, I'm overwhelmed at Full Script, or I'm overwhelmed at the health food store. And then Dr. Leonard Weinstock. These doctors are so busy. Please take advantage of the fact that they devoted so much time and energy in these presentations. Dr. Leonard Weinstock is an expert in, well, he's a gastroenterologist. He's an expert in MCAS, an expert in low-dose naltrexone, LDN, histamines. Phenomenal. Evan Brand, how mold mycotoxins create digestive and neuropsychiatric and marriage issues. Hello. Hey now, Evan. Here's Deborah Wayne, and she does a 7-minute high-speed healing technique. She's lovely and definitely has connected science with something a little bit more ethereal. Very nice for those of you who are in meditation or not. And Valerie Gettings, the gut and thyroid connection. I know somebody was asking about that. Here's Dr. Siebecker talking about tough SIBO. I think that's cases, Allison. It's a typo. Symptoms and solutions. Didn't catch that before. Jenny Tefenkian is talking about your brain inflamed, fear, fatigue, and brain fog, long COVID. Okay, she is a long COVID expert. Liz Lipsky, the microbiome and its systemic effects. For those of you who are like, I don't even know where to begin, watch that. Here's Ann Hills with more fatty liver. I think that's also a typo. I think she has another talk. I'll fix that. Decoding biofilms. If you cannot figure out why you are not getting better, you need to watch this. It could be a biofilm. That is a phenomenal class. And then transforming gut health, breakthrough approaches to outsmarting biofilms. I think watch them. I'm going to check on these titles. Here's Julie Greenberg. She's addressing the root cause of eczema. She is a functional dermatologist. Terrific. Here's Ken Brown. Dr. Kenneth Brown is an internal medicine doctor as well as a gastroenterologist. He created Atrantil, which is that methane treatment made out of natural ingredients. Fantastic talk. Hemorrhoids. So Crane Holmes and I met when I did the docuseries Digestion SOS. And I talked to him about one of his specialties is about dealing with hemorrhoids. And he's not into the online, teaching and stuff. He's got a great busy practice. But I asked him to come out in this platform to talk about hemorrhoids because, let's face it, most people don't, and they don't know what to do. And my friend almost died from a very severe case of hemorrhoids because she almost bled out. So I really want you to watch this. If you know anyone who has this issue, share it with them. Here's Jocelyn Strand also talking about metabolic syndrome and the microbiome. And then Sharon Stills talking about gut health. She's a terrific naturopath. Biologic medicine sounds like all medicine should be, but it's German biologic medicine. She's traveled all over the world, particularly in Europe and Germany, to study, and is truly, truly advanced. Are there other Q&As for the summit purchasers? We have Dr. Mark Pimentel coming up, and I'm not sure if Clarissa has put that in there. So, hey, Ramona, good to have you all here. Thank you all very, very much. PEMF, it's different than EMF. Let's see, here we go. Listen, Elizabeth, watch that with Crane Holmes because it is really, really important. More Indian Asia raw fruits for weight gain, suffering from huge underweight issues in SIBO. Dr. Siebecker, what do you say to people who are underweight?
It's such a problem in SIBO. I mean, there's two things we have to do. The first thing is we have to get in there and treat the SIBO. Try to get that bacterial amount down so you can absorb your food better, and not have symptoms that contribute to weight loss, right? Like nausea, diarrhea, etc. Right? So are you doing SIBO treatment is the first thing. Are you tolerating SIBO treatment? Do you have a test? Are you working to get that SIBO down? Second thing is there are all sorts of strategies for how to increase your weight while you're treating SIBO, while you're waiting for your test results, etc. If you are already doing meal spacing, do less of it. You have to eat more food more often. Of course, you have to find foods you can tolerate that aren't giving you awful symptoms. We also recommend doing things like drinking the elemental diet. That's easily absorbed, fast absorbed, and other beverages that have high calorie, right? So there's all sorts of things you can do there. Shakes, homemade lemonade, all sorts of things like that. It just generally higher calorie foods, more fats, finding foods you can tolerate, and just eat more often. I have like 15 suggestions, but that will get you going. And I just hope you're getting your SIBO treated. So it's a very common problem.
What is the elemental diet? It is a diet that it's a liquid. Okay.
It's a medical food beverage.
Thank you.
Of all of our nutrients broken down. So, amino acids instead of full protein, fat, and then the carbohydrates are not complex. They're simple carbohydrates, which generally we wouldn't think we want, but we do in this case. And then vitamins, minerals, and salt. And the idea is it replaces eating. And what it's trying to do, the mechanism is it's absorbing, because it's all broken down already, it's absorbing so quickly into the body that the overgrown bacteria and SIBO don't get a chance to eat it. And then it feeds us and it starves them. So the mechanism is different than an antibiotic, is it's starving them. But it can also be used not just for SIBO. It's used to rest digestion for inflammatory bowel disease, we heard Dr. Rezaie talking about eosinophilic esophagitis. Any situation where there's digestive issues and you just need to get nutrition, this will give it to a person so quickly it's easily digested. I mean, it's already pre-digested, so it's easily absorbed. And we can use it in all these different ways. It's considered to be anti-inflammatory. It's not something that makes you gain weight. It's not like that. It's just that why I was suggesting it for someone with SIBO who is underweight is that since it's pre-digested, it absorbs easily and it could help them get nutrition when they're having trouble eating or if they're having massive diarrhea or something like that.
Will the elemental diet cause weight loss, or can I use the elemental diet along with regular food? So you cannot do table food with it. You're only doing the elemental diet, and it's for usually about 17 days.
That's for SIBO. That's for SIBO.
Yeah.
For SIBO, we do it that's all we're consuming. But their question was, will it make me gain weight?
Will the elemental diet cause weight loss, or can I use the elemental diet along with
right?
regular?
Okay, so if you're doing elemental diet for SIBO, where that's all you're consuming and you're not eating food, we actually don't find that it contributes to weight loss, unwanted weight loss, so long as you consume the recommended amount. So because people who are underweight are worried, oh gosh, if I take this, will I lose weight?
Sure.
Have not seen that. You just have to make sure to consume the recommended amount, which is usually 1,800 calories or up to 2,000 calories a day. Sometimes what happens is people don't like the taste of it, or they're sick of it, you know, it's all they're consuming, and then they don't drink it. So that's where weight loss comes in. Can you eat regular meals and take it? Yes, but that's not a SIBO treatment.
Right. Right. Okay.
And where can you get the elemental diet? I see someone asking, you know, if you go over to, you can get it online, you order it, but I have a list of elemental diets you can buy in Fullscript. And of course, everybody has 15% off there through my dispensary. So Clarissa can pop that link in the chat. You can see a list of elemental diets there. So there's all sorts of options, and they have different flavors. Luckily, when we all started this, there was no flavored ones, and that's awful.
Okay. Okay, guys, this is what Fullscript looks like. And then you create an account, and Dr. Siebecker's, it's very quite intuitive, but it will take you right there. And then you can see all kinds of different suggestions, that Dr. Siebecker has created for people with SIBO, allergies. I mean, it
Yeah,
goes
if you
on
look
and on.
under plans, I think it's
Yeah.
community plans or something like that. I have plans already there for you, often with handouts, like I have all the elemental diets there, all the various treatments for SIBO, symptomatic relief suggestions for different symptoms, and my favorite supplements that I found work for those things.
And unfortunately, we don't do it for Canada. We
I'm
have
so sorry. We only
Yeah.
have this for the US. We so much wish we could.
Steve is saying, how do you take the elemental if you need 2,400 calories? How many breaks between shakes? Do you worry about the MMC and meal spacing, Dr. Siebecker?
You don't worry about that when you're doing an elemental diet. You can just take more scoops per every time you're taking it. Generally, it's a good idea for people who, if anybody has any kind of blood sugar issues, we don't really suggest taking just 3 shakes. And in this case, you would just, put more scoops in, and how many scoops, how much is going to be dependent on the product you buy. Like for each one, you have to calculate your calories, how many scoops you need to get that 2,400 in your case. But we don't recommend just slamming it down all at once 3 times a day, because there are a lot of simple sugars in it, and it can cause that hyperreactive hypoglycemia sort of situation. So we do recommend sipping it slowly over, say, 30 minutes, like you would a meal. So just keep that in mind. And you can do it more than 3 times a day if that is what works for you. We're not worried about giving time without eating for the migrating motor complex when you're doing an elemental diet.
Okay. So I think somebody said they're gaining weight. So they have SIBO and they're gaining weight. Any suggestions for them? And then we'll wrap up. Thank you all for hanging out with us.
Yeah, I mean, this is something I certainly hear from various people. The only real viable link we have in the research of how SIBO could be connected to weight gain has to do with methanogens. So if you have the methane type of SIBO, which is now called IMO, there's a bit of a link there. So certainly treating that and getting that down would be helpful. However, there are people who feel that they are gaining weight with their SIBO who don't have the methane type. And the link is it's somewhat tenuous. Like I've seen lots and lots of patients with methane overgrowth who have not gained weight. And so what I really think the best thing to do here, what I think has a stronger effect on weight gain, are hormones. Hormones can be affected by SIBO, but I think it's a very good idea to get a very good comprehensive hormone test, which is usually saliva. I know that that's controversial according to some practitioners, but really see a practitioner who this is their specialty. Have your hormones assessed for if they're in the physiologic range, and if anything's out of range, properly treat that. That is the biggest link I have seen with weight gain. There's one other that I do want to mention that's related to SIBO. Indirectly, and that's mold exposure. We see such a crossover with people who have been exposed to mold or living in mold. It's in their workplace, their car, their home. They don't know it. Maybe they do know it. And there is an association of gaining weight with mold. Of course, not everyone, everyone's going to have their own individual reaction. But so I would say, look at the hormones, treat SIBO and particularly methane overgrowth if you have it. Look at your hormones, get them tested, and then think about mold.
Okay. Angela, I recently self-diagnosed myself with IMO using the TrioSmart breath test. I used glucose and my baseline with methane levels were at 100 and stayed steady at 2 hours at 99. Could I also have SIBO? We're going to give you a distinction here because in a second. Since I've heard methane eats the hydrogen, I have chronic constipation and bloating with sporadic weeks of diarrhea. Thank you. Okay, doctor. So and Angela, it kind of sounds like you're thinking SIBO and IMO are separate. And I understand why, Dr. Siebecker.
Well, yeah, I mean, that's how Dr. Rezaie and Dr. Pimentel like to speak now. They like to say SIBO is when you have hydrogen or hydrogen sulfide overgrowth, and IMO is when you have methane overgrowth. But, you know, in my brain, it all started as SIBO. It just, IMO got a new name. But I think maybe what your question is, could you have, you know, the hydrogen overgrowth? Yes, even though it didn't show on your test, usually there is a concurrent or concomitant overgrowth of both. What will happen to so many people is when you begin the treatment, the methane comes down and then you see the hydrogen go up. And so so you know then that it was there. Basically on your retest, then you see you have the hydrogen overgrowth, aka SIBO. Still in my brain, I think of it all as SIBO. So yeah, but you know, and also I just want to say, I know you did the glucose, and of course it's all you could do, right? I would suggest in the future when you retest doing glucose again because it's what you did. But I would just like to say I really prefer the lactulose test because the glucose really only shows the very beginning of the small intestine. Dr. Rezaie, Dr. Pimentel, we all prefer lactulose. I know you, unfortunately, in the US, you need it prescribed. It's very difficult. Maybe you can't get a hold of it. But you can get a lactulose breath test on your own through Rupa, and we have put that link already in the chat. So, but for this particular case, because you tested with glucose, you probably want to do your retest with glucose because you want to compare apples to apples. But the thing is, if it's negative, then you do need to follow up with a lactulose because there can still be SIBO or IMO in the whole rest of the small intestine that the glucose hasn't tested.
Okay. For those of you who are talking about the oral microbiome in your teeth, yes, you're in one big tube, everybody. There's tubes within tubes, and your mouth and the rest of your gut are definitely related. And that's what biological and functional dentistry is. They don't separate the mouth from the rest of the body, or the, like, you know, the way medicine has done with eyes and with the mouth, they've separated them out. We're putting them back in. So you can definitely have bad breath from gut issues, dental hygiene issues from, you know, cavities, I should say. So please, please, please know that a biofilm plaque is a biofilm. So you want to really look at Dr. Ilana Gervich's talk as well. So I want to make sure that you all have all that information. I'm going to wrap it up because go to the summit, watch it, and then we'll see you next time with Dr. Mark Pimentel, and we'll be sending the link out. And yes, we will be sending you the replay of this. Okay. Thanks, Dr. Siebecker. So good to see you.
Thanks, everyone. Wonderful questions. Here's a hug for everybody.
Bye.
Bye.
Thank you. Thanks so much. All right. I'm glad we got to as many people as we did. I thank you. Thanks, Ramona and Steve and Sylvia and the gang and Clarissa. Thank you all so much for being here. This summit is really special. You may feel like, oh, I've seen one gut summit. I've seen it all. I've done 11 summits, you guys. I've had a lot of conversations with people. A lot of these experts were major gets. These were people that I've been wanting to talk to for years. And some of our most favorite, most requested, most educated and brilliant speakers over the years are also in the summit. So please poke around in it. It's free for 7 days. If you want to be financial and support the work and support yourself, we would love to have you do that. When you do purchase the summit, you also get the slides. The slides are money. They are loaded with information and searchable. And you also get the transcripts if you purchase. If you don't, that's fine. Enjoy the free content, but definitely get in there and learn, and then teach someone that you know and love, or a perfect stranger who will listen to you, what you learned, because that is the way we're going to heal the world together. Get this information out there. My goal is to have conversations and education that are not the typical doctor's appointment conversations. The company I started was Chronic Condition Rescue. These are conversations about lymph and fascia and dental issues and the gut and the liver and biofilms and the gallbladder and hair loss that are simply not typical conversations in doctors' offices. And I am pro practitioner, by the way, I'm pro doctor, but they have to stay updated with training and with research, and it's practically impossible. So you, as your own advocate for yourself, need to show up with studies and conversations and ideas and solutions and suggestions so that we can all help heal ourselves and each other. So thank you very much. This one is new. This is a new summit. It's not just the SIBO. They're covering all kinds of topics: GERD, adhesions, hemorrhoids, and I mean, so many things in the summit. So long COVID, the elemental diet. I mean, I just read the whole thing to you, so I'm not going to do it again, but please do sign up and get in there and watch it. Dr. Pimentel's talk is on the 21st. Oh, because the summit runs for 7 days. And then on the 21st, we're going to do something just like we did today. You're going to get a Zoom link. You'll show up live, or you'll get the recording, and that's how it works. But he does have a presentation within the summit that is fascinating. So that's how that all works. Okay. All right. Yeah. Watch the summit and bring your questions on the 21st. And once again, I'll do my best to get to them, but a lot of your questions are going to be answered by watching the summit as well. Mwah! Okay. Thanks, everybody. Take care, and we will talk to you later. All right. Bye. Thanks, Clarissa. Thanks, everybody. Yay. Oh, SIBO SOS Facebook community. I think I saw the link there, Clarissa. If you want to get in a conversation with 30,000 other people who are obsessed with SIBO, then join us in the Facebook group. Thanks. It's the SIBO SOS community. Look, if you've joined the summit, which, you know, most of you have here, you don't need to be in Facebook. Okay. You don't even ever need to go there. But if you want to be in a great, highly engaged, very loving, supportive, smart community to help you with your SIBO, very SIBO specific, then that is a great place to go. Okay, I'm going to hit it. Thanks. See you next time. Bye.